I thank Therapeutics, who is the institution, the organization responsible for marketing tissue of origin test here in India. And I'm speaking on their behalf here today. So, without belaboring, I'll bring you to some details of where this test is applicable. When we talk about tissue of origin, we automatically think of carcinomas of unknown primary, where we haven't figured out where the primary is coming from. In 3 to 5% of all advanced presentations, we are unable to figure out the primary. Mostly, the history is of metastatic presentation, aggressive disease, unpredictable metastatic pattern. Patients will present with weird metastatic sites, several sites of presentation, and a median survival with the best possible treatment historically of 11 months. When you look at the pie chart, you can see how 55% of these patients are finally diagnosed at autopsy. 20% will never be diagnosed, will never be given the name of a primary, and 25% only are diagnosed in the course of disease. A case comes to mind from my previous place of work. So this is a 25-year-old white male with 1-year history of smoking, collegiate smoker. Presents with 1 month of back pain, found to have extensive disease, brain, spine, lung, liver, bone, everywhere. No dominant lesion. Biopsy of a lung nodule, adenocarcinoma. IHCs inconsistent with lung, consistent with a GI primary. PET, upper-lower endoscopy, everything negative. Extensive workup, extensive IHC profiling. Then, so this is at Columbia Presbyterian, we had TrueSeq panel available. So we did a TrueSeq panel, 40 cancer gene testing. Patient was found to be KRAS G12D mutated, described in collegiate smokers in lung cancer. So I write an email to my molecular pathology chief, Alan Borzak, and I write to him saying, just by looking at the type of mutation that has been enlisted, would it be possible for you to tell me if this was lung versus GI, or is that asking too much? And here comes the answer. So for lung adenocarcinoma, if you look at the cosmic database, 16% of KRAS mutations are G12D versus 51% in pancreas. And that's the answer. So this patient was treated as lung because of that one single lung nodule, started on treatment with cis Alimta, brain radiation, spine radiation, went on to second-line therapy with Taxotere and Cyramza, blew past both treatments, died. And that's what is the inevitable end result of a lot of the CUP patients. If they get lucky, they survive to meet that median survival time point that I just mentioned of 11 months. And an unlucky patient, like the one that I presented, doesn't even survive to receive second-line chemotherapy or full second-line chemotherapy. What are we looking at improving when we are investigating an unknown primary patient? We are looking at figuring out biomarkers that would help us to guide the treatment, biomarkers to help us predict prognosis. In the West, not so much in India yet, but hopefully so, very soon, in clinical trials enrollment. So this patient that I talked about, a 24-year-old, how would one feel if I couldn't even give the patient a primary, unlabeled? So the patient goes without a label. You can't tell the family, the patient, what primary, what cancer they have, leave alone clinical trial participation. We did not have a CUP trial open, and I'll show a slide where the options, when we talk about CUP trials, what are the options that are there? So the bottom line is to try and figure out diagnostic and therapeutic interventions that will improve survival, especially for this cohort of patients. It has been shown that if you were to identify primary, and you really don't need trials for this, time and again, it has been shown if you had a tissue of origin, the outcomes would be better. In the era of precision oncology, we all know, and with a lot of dialogues to and against, for and against the concept, precision oncology still survives, where we all are looking out for pathways with which you could tailor your treatment better and improve survival for these patients. And some of us will feel, why not just go ahead and do a molecular testing for this patient? I feel we need everything. Because as we know, we can't have just a molecular clinic. We cannot have a BRAF clinic. As illustrated in this slide, you can see that a BRAF in colon versus lung versus thyroid behaves differently and has different results with the same drugs. Same drugs. So the context of tissue of origin is hugely important. It has huge treatment implications as well as cost implications. And you can see how a melanoma patient has different cost implications versus a lung cancer patient where different drugs are involved. And when you look at what is out there in CUP, you see NCCN guidelines where things are enlisted per adenocarcinoma, squamous cell cancer, small cell cancer. And then the entire gamut of chemotherapies are listed. They are basically thrown at the clinician to pick and choose from, to decide from, and the confusion stays. And this is an enlistment of clinicaltrials.gov, the trials that are currently ongoing in carcinoma of unknown primary, where most of the backbones are either with carbotaxol or gemcitabine-based options. Another slide that shows how in NCCN, gene signature profiling is not considered a standard of care and would not be recommended as a standard management or diagnostic tool for unknown primary patients. However, consumer drives today's world. And so I went to a CUP Foundation website, one of the most powerful CUP Foundation websites that I've seen. And there they enlist an entire portfolio of investigations that an unknown primary patient could have, including tissue of origin testing and 4 other gene expression profile testings that could be offered to the patient or may be of benefit to the patient. And that's where the knowledge of how this test results in treatment management change and has clinical implications comes in. And with that, I bring you to the test itself. And so tissue of origin test is a 2,000 gene expression profile testing. It's performed on FFPE samples. it categorizes into 15 different solid tumor types, and encompassing or comprising of 90% of all of these solid tumors. The test is known to be 89% sensitive, 99% specific, and the end listing of all the 15 tumor types is right here. When you take tumor sample, you perform gene expression profile, and you basically compare the gene expression profile of your patient's tumor sample to the bank of gene expression profile, the library of gene expression profile that you already have, that the company has, which basically classifies or compares it into 15 different tumor types and gives it a number. The number is called Similarity Score. And the report looks like this. So the test results come back to you as being of one particular cancer. And the similarity score less than 5 would be non-meaningful. Anything between 5 and 35 would be inconclusive. And above 35 would be positive for that particular cancer. In this particular patient, the diagnosis that they've come back with is pancreatic origin. This is a case that I'll present later. And some data into how this test has been very strongly validated and has had several publications to stand by. It is the only gene expression profile test for unknown primary that is FDA approved. One of these studies that stands out is how gene expression profile test was compared to IHC testing performed by 3 out of 4 pathologists who sat in a team. 157 samples were studied, and all pathologists together came in agreement to give a diagnosis in 83% cases, versus with the TOO test, you got 89% of concordance simply by doing the testing. Requirement of tissue sample is also lesser when doing TOO test than when doing IHC-based testing. On the average, in this test, there were 8 tissue sections required versus 4 for gene expression profile. And even in round 2, the agreement between pathologists fell short of giving answers in a huge number of patients versus higher number that were achieved in gene expression profile. Especially the difference was seen in poorly differentiated tumors, where this margin was even wider, as demonstrated in this table. Another study where gene expression profile helped decide whether the patient was in the category or should be treated with platinum-based therapy versus non-platinum-based therapy. So 38 patients were enrolled. Patients who were found to have tumors that could be treated with carbotaxol doublet were treated with carboplatin paclitaxel. The rest were treated with non-platinum doublet.
Dr. Limay, you have half a minute.
And these patients were found to have excellent response if they were treated with platinum doublet, and they were known to be of tumors that would have a better response with platinum doublets. In this particular study, you will see that after the GEP testing, the treatment specification changed in 50% of patients, and the treatment recommendation changed in 65% of patients. That number is a remarkable number. The study was run at major centers and the leading centers in the US and led to survival benefit of 3 months in this particular study. I will end my talk with actually a case study of my own patient, and I'll make it quick. So I have a patient who is 56, who presented with metastatic disease. There was a lung lesion which did not have a great PET pickup, but widespread mets to the bone. So if you look at the lower scan is actually with mild PET pickup. The upper scan is post 3 cycles of chemotherapy based as a lung primary. Patient was treated with carboplatin paclitaxel and had minimal response in the lung area and actually progression in the bony lesions. Clear-cut progression in the bony lesions. The initial pathology was inconsistent with the lung primary. There was a question whether this patient had adenocarcinoma originating from a GI tract, pancreatic versus gastric. Since there was a dominant lung lesion, the treatment and the diagnostic portfolio was all geared towards figuring out if this was lung versus GI, and the treatment also incorporated that thought process, and hence choosing a regimen with carboplatin paclitaxel, which would be applicable to both types of diseases. When the patient had progression, we re-biopsied the patient. Both the biopsies were taken from bony areas, but there was no decalcification performed. This was soft tissue deposit. And so the patient could undergo tissue of origin test. And mind you, the tissue of origin test is still not ready to be performed in a decalcified tissue. So this patient had re-examination with IHC, had molecular profiling of lung panel, which the patient was found to be all negative. EGFR ALK was found to be negative. And the tissue of origin testing was done. Patient was found, or the test results came back as of pancreatic origin. Based on that, treatment was changed. I don't have follow-up imagings after treatment, but this patient had significant pain in the bone, bony lesions, sternum, hip, and all those areas of pain resolved with 2 cycles of gemcitabine, oxaliplatin, and bevacizumab. That was given based on the current results. The thought process here and the presentation of the case is just in line with what should be attempted, should be done in order to figure out whether or not these patients can get better care, not just for better survival, but also for better quality of life, improved quality of life. Lastly, there are trials that are happening internationally incorporating gene expression profile. And one such trial that stands out is a study by NCI France that is incorporating gene expression profile to help designate a patient to a particular tumor type and cater to the treatment accordingly. I thank you, the audience, as well as the chairpersons, for being patient. Just didn't want to miss the point, and extremely grateful for inviting me here to speak today. Thank you again.